Ladies and gentlemen, thank you so much for joining us on this lovely sunny Friday evening in the UK, at least. So I'm glad you ignored the temptation for top up your suntan and have joined us tonight. This is going to prove to be a very, very interesting session. Looking forward to it very much. Um, we're going to be hearing a clinical psychologist, a qualified clinical psychologist, Dr. Sonia Frearson, who is the consultant clinical psychologist at St Mark's Hospital. And she's going to be talking about psychological aspects of major bowel surgery. And I think that probably includes most, if not all of us, in that. So obviously very focused on pouchy stuff. Most of her role is about securing funding and developing psychology services for St Mark's patients. She works clinically with people with intestinal failure, mainly as inpatients at St Mark's. And ladies and gentlemen, with no further ado, no further waffle for me, I'm going to hand over to Sonia.
Hello. So I will probably try and interact with you. So obviously do that if you feel comfortable to do it. If later on you feel like you definitely don't want things you said or comments relating to things you put in chat that I respond to, to be part of the video, if you can let us know. I think David and Gary are saying you can do that afterwards by email with them as well, and then that can come out of the video. All right, hope that feels comfortable. And yeah, do help me keep an eye on the time, David, as well, if I seem to be drifting too far. So I'll tell you what I'm thinking of covering in a second. I think that was quite a good introduction to me. I guess I want to caveat everyone by everything that comes next by saying I don't feel I'm a huge expert on bowel surgery or living with stoma or pouch at this point. Although obviously I work with people who have those devices and those experiences. So yeah, I think I will just change my view a little bit so that I can see the questions very well. But yeah, I was just curious whether this topic, talking about preparing for surgery, obviously we're thinking about bowel surgery with St Mark's in London in particular, whether this feels like a good topic for you this afternoon. And obviously, if you weren't expecting it to be this or me, there's no obligation to stay, and do just decide to join in with the bits of it that feel comfortable. If some of it's feeling a bit too much, feel free to mute or pop out and pop in again. I will probably give you a little sense of what we're going to cover in a minute, but there'll be a little bit where we might do a practice together, and I think I'll probably explain what we're about to do quite well, so you'll be able to decide whether you want to try that experiential exercise or not. All right, so I might move my view back again so I can see a few more people. Is there anyone who is actually preparing for surgery with St Mark's at the moment who wants to mention that or put their hand up?
So everyone's muted. So
Yeah, I might just do hands up maybe, unless you want to come with me.
yeah, a lot of people haven't got their cameras on. So if you haven't got your cameras on and
Okay.
you're muted, we're going to struggle to see you. A few comments in the chat, I think.
So I
No,
don't have chat open as well.
I had 7 and waiting for upcoming 2. I had 7.
Okay, that.
Oh yeah, okay. I think that's 7 surgeries.
Okay, so Barra has more coming. Um, yeah, and
Most of the people from that have had their bowel surgery, I think, have had their
okay,
pouch surgery, and I think it's safe to make that assumption.
great. So with that in mind, I think you're going to be experts by experience, people who've been through this before. So yeah, just to say then that you're likely to be experts through experience. So if there's anything that I'm saying that's not sitting comfortably or not feeling helpful, or you want to add to things, please do that. I may need help monitoring the chat, Gary and David, because otherwise the whole screen gets kind of covered in boxes. All right. So what I was thinking to say first, although now my slides are not advancing, I don't know why. There we go. was a bit about what we might cover. So I think for people who are service users of St Mark's Hospital, it's probably useful to say a little bit about where we're up to with psychology services. And I guess we're all probably aware that it's been painfully slow progress. I think talking about the IBD psychology service is probably the most relevant section, so I'll spend a little bit of time on that. We will talk about prehabilitation, which is basically getting ready to have safe surgery. And the reason for that will become apparent, but it is a topic of the talk really as well. And then I brought some materials and I wanted to credit my former trainee, Marielle Henderson, for helping prepare this material. It's stuff that we use for inpatient groups for people living with intestinal failure. So we'll say a bit about coping when you're in hospital and a bit about adjusting after surgery psychologically. We may even get on to self-esteem. Let's see. So yes, so what we have at the moment by way of psychology and mental health provision for people with IBD at St Mark's is, well, one morning clinic, I think, a month, or maybe two a month, maybe at the moment, with Dr. Moulton, who's doing a lot of research as a consultant psychiatrist into treatments for fatigue and depression, low mood for people with IBD. So yes, that's very specifically for people who have things like severe fatigue, IBS type symptoms going on in addition to their IBD. Both Callum and I, but mainly I, do some input for the team. So they have a sort of study session weekly called Gut Club, and we come in once a month to do a bit of discussion about complex care and care pathways for people. I've been doing reflective practice, so that's helping particularly the specialist nurses reflect on their practice, do some self-care stuff, talk about mental health and psychological care, skill up on consultation skills, that kind of stuff. Yes, as we mentioned at the beginning, we've both been doing quite a lot of work, Callum and I, on helping the service around research and setting up. And involved with that, I've been supervising an assistant psychologist, so that's someone with a psychology degree who's hoping to go on to train as a clinical psychologist, to do psychological distress screening and signposting to local services. So that's been people on biologics coming in for infusion treatment at St Mark's. So you may have encountered Nikki possibly in that context. And we're very pleased, after a lot of work and about 4 years in the pipeline, to finally have got somebody accepting a post. And they've agreed to do 2 days a week. We wanted a little bit more than that, but they're able to do 2 days a week to be the lead psychologist to set up an IBD psychology service. All right. So in fact, what I did at the beginning was have a look to see what we would need. So interestingly, St Mark's has an estimate rather than an exact figure on how many patients with IBD they think they look after. And they thought when I first came in 2020 that it was around 9,000 people that they look after with IBD. So if we use the needs analysis from Crohn's and Colitis UK charity, their estimate is that it's based on research findings in Brighton mainly, that you would need a full-time career grade, that's an 8A psychologist, for every 3,000 people that you're looking after with IBD as a specialist team. So St Mark's is going to need something in the region of 3 full-time 8A psychologists, which definitely justifies having somebody to manage and clinically supervise them in post. So that's the bit that we have, and what we're missing are those 3 full-time career grade psychologists. So it's quite a big need. All right, so I think you can probably answer this a bit better than me. But if you're living with a long-term condition, you are going to have quite a bit of psychological need, because long-term conditions are difficult to coexist with and live with. And they do tend to push up people's distress and stress levels generally, which makes it more likely potentially that people will experience depression and anxiety. And IBD isn't any different in that respect, and may have aspects that make it challenging and more difficult to live with than other long-term conditions. Unfortunately, people in psychological distress are at risk of suicide, and people in psychological distress are probably a bit less likely to be able to manage their condition well than people who are in less distressed at that time. So then they're going to be at risk over time of having worse health outcomes. People with long-term conditions and mental health problems are a bit more costly for healthcare systems to look after. We can get into why if you're interested, but yes, that is definitely a consideration, which often justifies having a bit more specialist mental health provision in physical health settings. And so one of the specific things about people living with IBD is the interactions between the brain and the gut. And so that means that you are likely, if you've got low mood, anxiety, or more likely to have recurrence of IBD symptoms, so to have a flare. So these are all good reasons why it's important that we have psychology in these settings. I'm not sure how helpful this will be for you, but just to explain that if you are having specialist psychologists in a physical health setting like IBD at St Mark's, we're not trying to duplicate, replicate, or what's the other one, sort of, take over from in any way the mental health system that already exists. So we are expecting at the bottom of this stepped care pyramid here that everybody from the cleaner onwards has the ability to recognise people's psychological needs and provide compassionate care and communication with people, and be able to help people get to mental health care if that's needed in a timely way. So at tier 2, at step 2, we might be providing some additional skills and training for people in the way they help people and use consultation skills. So motivational interviewing is one example of that, which you might find all sorts of people like nurses, dietitians, physios using. So the bit that does exist out there for people with IBD and all sorts of long-term conditions is now called NHS Talking Therapies, but it was called Increasing Access to Psychological Therapies, IAPT for short. And yes, they are deliberately commissioned to help people with long-term conditions and anxiety and depression. So as part of our funding model, really, we're still expecting people to use that level of local care where that's appropriate. But the bit that we're missing, that we just talked about, the 3 career grade psychologists, that's really around helping people living with IBD, so having the best life that they possibly can, despite living with a challenging condition, so helping with quality of life, helping people where self-management has become tricky for various reasons, the beliefs that they have, the condition, the cause of the condition itself, all sorts of reasons why that might be tricky, because they're also trying to manage a mental health condition as well. And we might be helping people who over or underutilise their NHS care, and people who may be sometimes presenting to A&E or over-presenting to A&E, trying to figure out what's going on there and if we can support them differently. And just reminding everybody, but this is very important if you happen to be a health professional, that there is another level of care out there above us, which is particularly addressed at people who might need immediate mental health care. So they might be in crisis and considering harming themselves in some way. And there are specialists in that category as well. At the top of the pyramid, there are some specialist mental health services, learning disability services, eating disorders teams, substance misuse teams, which are really important. And again, we're not trying to replicate or replace that kind of care. So people may well get streamed to other services as needed. All right, so once we do have some psychology for IBD, it's likely, because again, it is a very large centre at St Mark's, that we'll use the same model that's been worked up at Guy's and Tommy's and Addenbrooke's for people with IBD, to have some sort of joined up care, I guess, where the psychologists are joining in with the MDT clinics and will be like literally in the room with other members of the team and offering things a bit like this, like workshops and group work for people, so we can try and reach everybody rather than just trying to target people who might have a mental health problem. All right, so yes, there might be some things that are very particular to this setting, like trying to help people with their medical decision making, where they're a bit ambivalent about surgery or particular treatment, or feeling quite hopeless about trying yet another biologic, that kind of stuff. And again, psychologists are likely to be embedded in the hospital system, so they'll be best placed to help inpatients, where the issue isn't about people wanting to self-harm in some way, because that would go to level 5 again, and psychiatric liaison teams. All right, so we are very much hoping that we would co-produce the kinds of things that the psychologists will lead on in a group workshop programme. So for example, it's likely we'd want to co-produce stuff around fatigue and IBD, pain, abdominal pain, sleep, getting on with your life, so being able to do things like working and parenting, being in a caring role, and living with anxiety, low mood alongside physical health conditions. So my particular therapeutic interest is in the third wave therapies, including using meditation. So that's mindfulness based cognitive therapy in therapeutic settings. So I think there is some evidence for that in gastropsychology settings. So I think that might be helpful to explore together as well. And we've really done a little bit of exploring Tree of Life workshops. So that's a bit exploring what makes us individually human and more of a storytelling drawing approach together before we start talking about the stuff that's a bit more challenging about living with the challenges of IBD together. So it works well for everybody, but I guess young people it appeals to very much. Okay. Feeling a little bit cut off from everybody, so I hope things are going okay. I don't know if there's anything more in the chat that I should have a check.
There's nothing,
This now. No,
nothing in the chat. No, don't worry about that.
Okay.
Crack on.
Excellent. Good. All right. So prehabilitation, just so people who may have popped in after I said what that is. So that's a new-ish surgery service rather, which is an adjunct surgery teams at St Mark's. I think it probably exists in other settings as well, but it does seem very new to St Mark's to be doing this. The idea really is to try and achieve best outcomes for surgery for everyone. And we're thinking obviously not about emergency surgery. So at the moment it's an MDT, and we did make the case to have psychology from the outset in the MDT, and that wasn't just me, that was the anaesthetist and the gastroenterologist and the physios all making that case, and yet the psychology was the bit that didn't get funded. Anyway, we've slightly won that argument now, and there will be a post to add psychology back in retrospectively, and hopefully the whole service collectively, on the basis of the evidence that they've been collecting for the last few years, will get the whole MDT, including the psychology bit, funded for the future. But anyway, this, if you're going to have surgery at St Mark's at some point, is likely to be what happens. And if it doesn't, and you feel that this would be helpful, please do ask to see the pre-assessment, the prehab service. All right, so part of the remit is to just make sure that everybody's on the same page, that people actually are in agreement that surgery is the next step for them and it's what they want to do. If there are considerations about when surgery might be a good idea, that gives people an opportunity to share that, have a think about that. And planning for discharge obviously starts at that point as well. So if there's going to be some discussion with people who might help take care of you at home after surgery, that will happen. Or if there's going to be some difficulty around that for people to be discussing that from the outset, really, and starting to think about any adjustments so that it's more the occupational therapists and physios domain that might be needed after surgery to help get people home and getting on with life again. So yeah, the team will spend some time on everybody's complete kind of health. So people are living with my previous specialism, diabetes, in addition. They will definitely have a bit of conversation about how well managing diabetes is going and trying to improve that in time for the surgery. But all sorts of different medications might need to be examined and have a think about whether things are optimized at the moment or need reducing, coming off. So pain medication fits with that, which we've got lower down the list. So there are physios in the team, and the idea there is to help people improve their cardiovascular fitness, because that's closely linked to good outcome for surgery. And also just to help people with the message that getting moving, even though that will be, I mean, at the very least uncomfortable, probably painful after surgery, is very important for good outcome, and how they will be supported and hopefully meeting the same professionals before and after to do that bit of work. Yeah, so some of that will be around managing weight. So less commonly for patients in my bit of the pathway, it might be about reducing weight. It's normally about checking on people's nutritional status and optimizing that. And it may mean that people come into hospital for a while to try and gain some weight, actually, on parental nutrition or other forms of nutrition first. So that might take a bit of thinking about for people, because they may then be adding, you know, some weeks or even months in hospital before they're ready for surgery for that reason. In particular. So again, things that, you know, might be lifelong things that take a while to try and make a difference with. But again, just making the case really for people to reduce their smoking or stop, ideally. Similarly with alcohol use, or, you know, explaining why it's just not going to be possible to do the surgery because of various other factors that are going on for people that haven't been amenable to change very quickly. So even in the absence of us having some psychology in the team have been screening for psychological distress and using us to help them signpost people to services, and having a bit of discussion about whether people, again, feel ready for the surgery at the moment, or whether they need to deal with the other thing that's going on that's leading to distress for them. But I think having psychology in the service is going to make a big difference, and hopefully will help people with some of those big behaviour change you can see there about maybe reducing pain medication, trying to increase or decrease weight, trying to get physically fit, trying to stop smoking. All of that stuff will be easier with a bit more psychologically informed ways of working for everyone in that team. It's stuck again. Come on. No, they are.
Not happy.
It's not letting me move forward. There we go.
There you go.
All right. So the little thermometer on this screen, I guess, is an example of ways psychologists help people sort of communicate how distressed they're feeling. So Nikki, who I mentioned before, when we were looking at the level of distress or screening for anxiety and depression with people in the biologics clinic, we did devise a way of using a distress thermometer so that people can just give us a score here and now for how overall how they're feeling, how distressed they're feeling. So this is a little graph as someone prepares for surgery about how they're feeling. So these scores, I would say, are quite typical. Actually, when we asked people in the biologics clinic to rate their distress, in general, people's scores were below 5. And a score of 4, yes, that did correlate actually with anxiety and depression often, but that was the mean score. So you can see people don't rate themselves highly on there, but it still is very informative, I guess. But you have to have an idea what the average scores are likely to be for your population to interpret it. But anyway, this is just to give you an idea about how somebody's distress might vary, for example, when they're thinking about coming in for surgery. So yeah, maybe just getting ready and packing, that's not too upsetting. Yeah, relaxing, having a meal at home, that's fine. Having a shower, that seems to be bringing to mind going into surgery a bit more, maybe. Yeah, sleeping, luckily that's going fine for them. But then the next morning you can see their distress is going up, and particularly as they come into the hospital and have to start doing different tests and measures. Yeah, I don't know why getting hospital wristband was less distressing, but that's good. And interestingly, meeting the surgeon, that's been the peak for that particular person. Yeah. All right. So I think I would make the assumption, and certainly Mimi, who helps make the slides, we'd learned together that that's kind of the default position for people on the unit where we work, that people find being in hospital difficult and anxiety provoking. So I don't know if that's true for everyone here, but that certainly seems to be people's general experience. So we just said a little bit to people who are in hospital with us in the inpatient group about the fact that that is quite normal, and the function, I guess, of worry, of fear, is to keep us safe. It's a sort of automatic response the body has. We'll say a bit more about models explaining that in a second. But you can sort of balance that fear, anxiety response a bit by trying to build your confidence, I guess, in the setting. I think there might be a bit where I ask you. No, I don't ask you at that point. We'll have a think later if there are some things together that might help with building confidence when you come into hospital. But I guess to give a few examples, I guess if you know the team that you're coming to, that might make a difference. If it feels clear what the procedure is and what's going to happen afterwards, if you've had a chance to talk, or you're going to get that chance to talk to the pain management service in hospital, those are all things that build confidence. If you've had previous experiences of good care, that will help. If you've had not so great experiences of previous care, particularly in this hospital, that's not going to help. That's going to build the fear side, so that might need addressing a little bit with the team. Yeah. So this is probably a model of psychology that I don't know how many people will have encountered before. It's a compassionate mind therapy. Yeah, if we say a little bit about that, it comes from a sort of biological psychology perspective, I guess, and it also borrows heavily from sort of Buddhist ideas and perspective also. It's talking about different systems, like so neurotransmitter systems that we have around emotional regulation. and how those interact. So maybe I'll just work around this diagram. So yeah, the drive system, I guess that helps us get stuff that we need to survive, partly. So food would be a good example, but it will also help us with long-term things. So, pursuing, I don't know, education or partner, all those kind of things would be, yeah, part of the drive system. Our fret system, that relates to the sort of fear bit of the seesaw we were just looking at. So that's where our system has evolved, as for all animals, to keep us alive, basically, in a situation where our life might be in danger. So that's the bit that will help us run away or freeze or fight if we're threatened. And hopefully balancing this for all of us is the soothing system. So that's the bit really that helps us nurture young as well, but it's the bit that helps us rest and relax and digest, and yeah. And for most people, without getting too sort of individual, those three systems just typically, as well as at different points in time, are not necessarily in balance. It's more likely that one or two of those systems are going to be predominating, and that may or may not be so helpful or adaptive or comfortable to be with long term. So again, you can see for an animal like a zebra, if they're faced with a threat, then their threat system will help them get away. Let's guess it's a lion that they're getting away from. So they get away, and that response sort of dies away, and they're able to rest and come back to, being soothed and safe quite quickly. Unfortunately for humans, we've got a new set of additions to our brains that help us do all sorts of wonderful things, like, I don't know, devising computers and coming up with art, but it also helps us keep thinking about stuff. So we might criticize ourselves, like, why did you run away from the lion? You could have fought it. That was stupid. And so or you could have died, and imagining exactly what that would have been like and the effect on people around us. And so that distress, that fearful response, that anxiety is just going to keep going because of the ability our new brain has to keep thinking about it, ruminating, psychologists would say. All right. So again, thinking about surgery and things that might help or not help, it's likely that people will experience pain post-surgery, isn't it? So the idea obviously is to try and help people manage that and not be in a level of pain that's intolerable. But as we were saying, people are going to be asked to try and get moving, and that's going to be at least very uncomfortable, but will be in everyone's best interest to try and give that a go. So this might be a bit of experience that people have with living with pain or living with long-term pain afterwards, that they're really trying to do stuff like the rehabilitation after surgery, but the pain is stimulating their threat system and making them feel very distressed and anxious about what's the meaning of the pain, why does it keep coming back, why is it so strong, and other things that can happen around experiences of pain. Or when it is well managed, when you're in less pain, then people might decide to do a lot of stuff, and then unfortunately the correlate of that might be that then they're very exhausted by doing so much stuff which they haven't been able to do for a period of time, possibly. So that cycle also is possibly not so helpful to be with. So yeah, again, this model will advocate that the answer really is to try and also activate the soothing system. So trying to be compassionate to yourself, understanding that pain is part of the picture at the moment, but also trying to take care of yourself with that. So maybe trying to do the rehab stuff, but also having some boundaries and not trying to push too hard and get yourself doing things. All right. So yeah, activating soothing systems. I think that might be a good thing to have a little look at. Yeah, does anyone want to contribute a bit there? I will try and come back so I can see you a little bit more. There we go. Yeah, are there any things that you might do, particularly thinking about being in a hospital setting, being in a less familiar, possibly for most people less comfortable to be in situation, that might help you sort of rest, relax, soothe? What helps when you're in hospital? pop any in the chat. This is where it gets complicated trying to open everything. I've done it.
I used to find that talking to people helped me, not
Mm.
necessarily about me or my stress, but just talking to other people, just relating to other people.
Yeah, and someone was remarking to me lately that she's stopped saying yes to people visiting her in hospital because they expect her to talk about herself, and that's not helpful. So we had a bit of a conversation about just explaining that's not necessarily what you want. Yeah, and that you want to hear about them and their life and what's going on, and that's helpful. Yeah,
Got a
distraction,
couple of
yes.
comments, yeah. Music.
Music, I think that's a great
Actually,
one. I feel like I have to always caveat music by saying it's a really good way of evoking emotion, though, isn't it? So you might have to just really curate your playlist, whatever, really carefully. So it's not provoking you with stuff that's going to, yeah, make you feel more anxious or whatever it might be that's not helpful. More like getting up and moving around when you can't do that because of pain. Dogs, yes, we are endlessly, it seems, on my unit exploring whether we can have therapy pets coming in. Guided meditation, we'll get quite close to doing some of that in a minute, but yes, that's great. Yes, very pets. Yes. So again, it's worth, I mean, definitely with St. Mark's, it's worth saying to them, you're a long way from home, that you'd like also to be able to have a pet come and visit, because we have managed to negotiate for that to happen before. Yeah, being in nature. So this one I find quite tricky. I don't know if people have been in hospital at the new St. Mark's site. I feel like it's pretty cut off from nature, in fact, and their garden spaces are hard to find. Do ask the staff. You can find bits where there's slightly more trees, shrubs going on at least, but it's not easy. So I think what we'll do next is try and help with that. But I think if it was me, I would try and, yeah, think of some videos, maybe some pictures, and maybe ask if I can put up pictures and photos of nature. That's going to be something I'll miss. Yeah. So that's a bit of a gap that we have. Does that feel like enough?
Yeah, what sort of music? I mean, are we talking AC/DC or what?
Well, I think it's going to be quite individual, but I guess if you really enjoy music that you normally dance to and you've just had surgery and it's quite painful, that might, I don't know if that's going to feel difficult. So just holding those things in mind and thinking, okay, I'm actually going to deliberately select some things I wouldn't normally listen to, which I might find I don't have an association with, but I gather that this might be relaxing music for other people. Give this a go.
Yeah. Yeah.
But yeah,
Yeah.
lots of people enjoy singing. And again, if that's going to be painful and you're not able to sing along, then that might not be the one. But it might be that, yeah, you're missing singing. So you want to be able to do that. Yeah. Again, we're trying to encourage on the Ramwood Suite, at least for people to use the group room a bit more. And that has a keyboard. So, people can literally come and practice with headphones on or out loud if they want to, and offer singing for each other. So yeah, they're all very welcomed. I'm going to close the chat again, but feel free to contribute things and hopefully people will just let me know. Oh no, it's got stuck again. Let's see if I do a bit more clicking, if it will let me. Come on, we're going to move forward. Yeah, come on. There we go. All right, yeah, so I was just going to mention to you special place imagery. So this is worth maybe doing a little bit of thinking through before you're in a situation, where so for example, if you're going to the dentist, most people are not super relaxed at the dentist. My dentist generally, if I'm looking up, I can see the sky, which is helpful for me. And at times where I'm in a room with them and I can't see the sky, I would use some special place imagery. So not for everybody, a beach, but you might have something. So some people might have a particular place, a physical place that they go to that's very relaxing for them. They give you a few examples of ones people have used: woodlands. Yes, definitely coastal scenes of different kinds, maybe even their own bed, being at home, a room at home. Yeah. And in the image that you try and devise, so that the idea is that you can take this anywhere, that you're not asking somebody to hold a picture in front of you, and that it can then help you try and go into that self-soothing state a bit more. If you can try and use as many senses as you can, that's helpful. So that's possibly why it's a good idea to rehearse beforehand. So for example, if it's the woodland scene, you might be able to think about the sensation of the wind, possibly the breeze on your skin, or the feeling of sunlight on your skin, for example. You might be able to, if it's like springtime, you might be able to smell flowers. They're trying things. So try and make it as rich with different senses as you can. so that it, again, acts as a distraction, if you like, and takes you out of the difficult situation that you're in a little bit. All right. But as I was saying, if you're thinking about just being on the ward and the fact that we're not so surrounded by nature and you can't bring things with soil and plants into the hospital so easily, yeah, if you can have some images and videos lined up that would help you, that's useful, I think. So this is the bit where you might decide this is not for you right now. I would say this is a great psychological first aid and it's good for everyone, but it may not be. So I will just caveat it that if you don't want to join in with what we're about to try, then you don't have to. But I was just going to say we can do some stuff that might feel similar to meditation, but this is a little bit, we can explain the theory, I guess, behind this exercise in a second. But again, this use of breath will connect with that self-soothing drive. All right. So this is your cue if you feel like this is not for you to tune out or to turn sound off for a minute. All right, we're going to have a go at diaphragmatic breathing. I'm not sure if people have tried this before, but we'll just have a go at re-explaining it. So you probably can't see very much of me, so I'm going to try and narrate. I apologise, it's probably much easier if you're sitting with me and you can see well. So the diaphragm is that sort of bell-shaped stuff that's going on under your lungs that helps with breath. And to try and discover that, I guess, what we could do is maybe put one hand on your chest and one hand on your belly. So we're hoping for below the rib cage when I say belly. All right. And then just notice as you breathe in and out, the movements of your hands. And what we're going to try and do, so when we're anxious, we're much more likely to be using intercostal muscles. So that's the muscles in the rib cage, which means you'll probably, again, I don't know that you can see me, but I will do panting so you can hear me. Much more likely to be breathing like that, which is tiring. It also changes the blood gas ratio, which is quite literally leads to a set of symptoms which are very unpleasant, like dizziness. We'll probably connect with feelings like nausea quite quickly that go with our anxiety response. So to counteract that, you don't even have to notice that that's what you're possibly doing. We're just going to try and breathe using the diaphragm much more. So your lower hand, the one that's hopefully on your belly, just below your diaphragm, we're going to try and move that hand and not the top hand that's on your chest next. So if you inhale, yeah, hopefully the belly's going out, and exhale, and you'll feel your belly go in. So we just have a little try. Okay. So I would suggest, again, it's good to practice as we're doing now, hopefully in a situation where you're not feeling anxious, so you feel a little bit familiar with that. And, if you're in company, if you're on a ward, it may feel a bit self-conscious to do it by touching your body to find, get in contact with that. So if you've practiced it and you can do diaphragmatic breathing, belly breathing, without having to have the hand there, that's all to the good usually. And I would say probably 3 deep breaths out will do it in most situations of acute anxiety to help you kind of cut that cycle and start to relax, calm down, come back into the present. So it's good to practice that. If you are an experienced meditator, you can definitely see that you can use your skills of mindfulness. So bringing your mind, your awareness, your attention to follow the breath as you do that. All right, I think, how are we doing for time? We're doing okay. So this was just I don't know if did somebody say something in the chat? I can see a little.
Yeah, just reading it.
And,
Belly breathing is great.
yes. I wandered over to say something, so thank you, Beryl. Yeah, and there are times where our breathing might be troubling in other ways. So, for example, I have asthma, so there might be times where I don't really want to bring my awareness to breath because I might get into more of an anxiety spiral about why that is difficult or why it's wheezy or painful in some way. So in that situation, what you could do is something called grounding. So I haven't brought a slide on that. You can do grounding in a number of different ways. So, for example, if it's a situation, like going out of the house makes you feel a bit wobbly, a bit anxious, you might want to do grounding, perhaps using an object that you'll have with you. So sometimes people will have a sort of sensory object on their key ring, for example, that might help them get out of the door. But you can do grounding, yeah, again, a bit like we did with the special place imagery, by trying to use as many different sensations with that object as you can. So it might have different textures. Let's imagine it's a fluffy tassel. It might have different colours, so you could describe the colours to yourself, really try and notice the different colours that it has. You might deliberately put some essential oil on it, if that's okay for you, so that it will have a smell, and all of those things can help you come back into the present. So another one, if you don't have an object to do grounding, you might want to do a bit of noticing things that you can see around you and just name them to yourself. So maybe try and think of a few things that you can see. Again, try and notice things that you can hear. And again, you may struggle with things that you can touch, depending on where you are. But you could try things that you could touch, or, and that would include things like the furniture you're lying on or sitting on, and the sensations you can feel from those. Again, you might struggle with taste or smell, but then there might be something, and it's certainly worth noticing if there is nothing that's not troubling at the moment. So there's other ways of trying to work with acute anxiety and try and access the soothing system. Thank you for that. All right, how are we doing? We're not doing too badly, I think, with time. So yeah, so adjustment. So that's, yeah, accommodating, living with, yes, your particular condition or what's happened post-surgery where you are. All right. So yeah, it's probably pretty normal that there'll be lots of strong emotions around, and some of it might make sense and some of it might be a bit puzzling. So yes, if there are people around who you trust, who you can talk to about those feelings and try and express it or make sense of it, that might be a good thing. But typical feelings that might be around for people recovering from surgery, there might be some things that have made you feel quite angry, or that there might be some disappointment, and that comes out as anger as well, with the results or what's happened or the care that you had. There might be some shock because things may never be exactly as we expected. People might feel quite numb and cut off and a bit confused about why they're not feeling anything, or why they're not experiencing the pain they thought they would be in. So that's a possibility. Yeah, we've talked quite a lot about fear, anxiety, and that's quite a normal thing that might be around, but also might be starting to have fears about, am I ever going to recover and get back to myself? That's that kind of stuff coming up. All right, so thinking about different strategies. My slides got stuck again. Come on, there we go. All right, so I started mentioning this already, but yeah, seeing if you can label what you're feeling and express it. So trying to acknowledge and express things. It's not necessarily helpful for everyone, but if that is a useful strategy for you, just reminding you about that one. So yeah, if you can manage those emotions in some way, that's great. So we've talked about a few ways that might be helpful about being in that difficult, unfamiliar situation in hospital, or what might help with hold in mind with pain, for example. Those are all examples of self-management. Yeah, and then thinking about ways of restoring psychological well-being. So these are all much longer questions to unpack, of course, but I'm sure we all know for ourselves things that do contribute to our psychological well-being. So you talked about a few, I think, when I asked you what helps. So it might be those people close to you, being able to maintain that contact with people and still hearing about what's going on for them, even with the difficulty you're going through. It might be, yes, having contact with pets, having contact with nature in some way. Being able to think about what's meaningful for you, which might be connected to all sorts of things, your caring responsibilities at home, being a parent, being a pet parent, all those kind of things might be connected with your role, your employment. So yeah, starting to maintain those connections and think about what will happen next in those domains, all useful. Yeah, and trying to have a sense of control as well. All right. Do you feel like, telling me a little bit about what's helped, I guess, what's helped you, where something has changed and you have to adjust to that, and it will probably be a choiceless thing or something you agreed to do, but yeah, it has left you in a different place. What helps you cope? What makes a difference? We might want to put them in chat again. I've given you too many examples already.
I'm
I
just
think
thinking about the.
having a think.
I'm just thinking about there are three main reasons why they have people have their large intestines out. Um, One is an emergency for ulcerative colitis, and that's an emergency. You have very little option
Choice or
about that.
preparation.
One is for cancer, and there might be a little bit more of a lead into that, depending on the circumstances. And one is completely different. It's an elective surgery. The timing is elective. It's for a genetic condition called FAP,
Yes.
where people are fit and well and healthy, as opposed to the other two examples, where their lives are very much under threat. With FAP, you don't have an instant immediate threat. You have a potential threat down the line. And I think that's a very different circumstance in terms of the psychology of accepting all of the pain and the inconvenience and all the discomfort of surgery. If it's going to be life-saving, that's one thing. And I think we would all agree that the pain and all the inconvenience is worthwhile or more worthwhile. Whereas with FAP, I always think it's very difficult for people who are well and who feel well and who have no overt issues to then go for this very large operation to have their large intestines. And then after that first phase, you've got you're given the option of further surgery, usually two surgeries, one of which is huge, which will result in hopefully a pouch if all things go well. So compared to the first operation for people who've had cancer or ulcerative colitis, where they had no option other than death, you've got then two operations which are elective, which you choose to do. You'd have to have one anyway. Yeah, but they're very different psychologies. And I wondered if you'd like to comment on the psychology of elective versus emergency surgery and whether that's relevant for our attendees.
Yeah. I mean, yes, I'd be interested in people's thoughts about it as well. But yeah, again, we're trying quite hard to get someone in post to help the population with FAP because I think that's recognised, and I think the team have talked to me about the fact there's a parallel with women living with BRCA genes, and that they
Yeah.
do have mandated that they should have some counselling, some opportunity to talk about this before they elect to have surgery, and yet it's not the case for FAP, or it's not thought about in the same way.
Yeah. So
Yeah.
BRCA genes is where they have their very high risk of breast cancer, and but they may be perfectly healthy, but they're being counselled on the basis that they should think about having very radical surgery because of the risk of the genetics that they have. So that's very similar to FAP, I think.
But with much more recognition, I guess, that there will be a huge psychological impact, and that's going to be a tough choice to make, and that people will often be left feeling perhaps I don't know if I made the right choice. Yeah, chose to do this at the right time for me.
Yeah. Yeah.
Yeah, and I think people get much more access to psychological care if they're living with cancer. It's probably true in our service as well, though we would like to be again offering more care while people are inpatients for sure and before.
Mm-hmm.
Yeah.
With pouches, there's often an issue about shouldn't I? Because the alternative is to have a stoma. And a lot of people cope very well with stomas. It's perceived as having fewer complications. But a lot of people, most of this community included, will opt for the pouch surgery, which is a longer journey, potentially more complications, but the outcomes can be much better. And that's again, I think, an interesting psychology. We have a lot of people come to us who say, "I'm thinking about the surgery," but they may have read stuff online or gone onto a forum and seen a lot of issues and problems, and they they're worried, they're anxious about that and the outcomes. I mean, we can't guide them firmly one way or the other. It's
No.
not for us to do that. We're not clinicians. So and it would be inappropriate. But often people will say, well, it worked out fine for me, which is great, which is really great. Or indeed, it didn't work out well for me,
Yeah,
which is
I think
very,
that's important, isn't it? To be able to hear
yeah,
both sides of that and have a think.
yeah.
You
But
can't know,
that's
I'm
not the
guessing, whether
problem.
that will be you or not you, but it's good to, yeah, to hear both sides of it. It goes well or it doesn't become what I expected it to be.
Yeah,
Yeah.
yeah,
Yeah, I think it does adequately again make the case that people should have access to psychology because it's slightly separate, I guess, from talking to the surgeon or the clinical nurse specialist about those options.
yeah,
Because hopefully the psychologist can be a bit apart from that and a bit less invested in trying to persuade people in one direction or another, even if they're just doing that through unconscious bias.
yeah, yeah,
More
yeah,
explicitly trying to hold a space that's neutral for people to think about this and the implications for them or for them and their their loved ones.
yeah. And everyone's different, aren't they? What about chronically ill? Because some of our members suffer things like pouchitis, um, inflammation of the pouch, and that can be all those things that you put up on the slide about demoralizing, debilitating. Um, are there, I mean, are they the same psychological tools that you've talked about in terms of coping with the stress and maybe thinking? I read in your a CV about cognitive behavioral therapy and positive thinking and mental positivity. Are there roles for these sorts of approaches for people who are feeling down or fed up about chronic illness?
Yeah, possibly. I usually take the starting point as someone, yeah, kind of comes and describes their sort of health situation and what that experience is like for them by having a think about, whether there's anything here, at the risk of sounding very medical again, but whether there's anything that needs to be optimized, whether that's okay, whether it makes sense to me that they're left living with that, whether it's like, no, I think I want to have a conversation with the team to check whether anything else can happen, or do you want to have that conversation, or shall we do that together? How can we do that? How can we get more information?
Mm,
Particularly for me, still finding out about living with stomas and pouches, that's often how I feel. Like, is that right? That doesn't sound, yeah, that doesn't sound very possible to live with. There must be, there must be something else they can offer. And then we discover together, or the person already knows, no, this is it.
yeah.
Okay, so where does that leave you then? What do you want to do? Are there other options? Are there more surgeries you've considered? Yeah, so it may not be, I can hear the small person's about to burst in. It may not be, yeah, the situation that we're just using cognitive behavioral therapy, CBT, to try and help people stay with a situation, because that may not be right for them. And sometimes that might be about helping people advocate for themselves, or yeah, have a think about whether they would like another round of treatment or possibility or discussion about that.
Mm,
Yeah, instead. But yeah, sometimes we might use some techniques to think about living differently with pain, or being able to have a different quality of life, I guess, or get back to things that they were able to do before, despite the fact that things are different in some way. That there might be a stoma bag, but they're not quite okay with being there, for example, and being able to get back to work, or yeah, hobbies that they valued before, for example.
mm. Right, I've got quite a few questions, but I'm not gonna hog this opportunity. So do please, audience, if you want to ask questions.
Do you want me to come out of the slides? Is that distracting?
Well, I think we've got looking at the time, we've got a short time left. I think it would be a great opportunity if people have specific questions relating to their own circumstances, or indeed general questions about what you've been saying about relaxation, about coping with the stress of chronic conditions. Then please feel free to ask away. Otherwise, I'm gonna ask all my questions. And you've got a little man who's Sonia's got a man who's just turned up, and so he probably wants a little bit of
Because
time
he's
with Sonia. Everyone's smiling that I can. We've all been there. Let me Does anxiety contribute to inflammation?
I haven't done a sort of full literature review on that recently, but I think the likelihood is yes. Hello, small one.
There he is.
Yeah, you're talking to some people about, yeah, living with their difficult guts.
Hello, young man. Who's this?
This is Ephra.
Hello, Ephra.
No.
How was school?
Good. Excellent.
Great stuff.
We started making you a drink. We go and ask him. Yeah, good idea. Yeah.
Oh, good psychology there, Mum. So stress, I mean, stress is something which I believe we
He hasn't made it yet.
oh, he hasn't made it. Oh dear, we're in trouble. Stress has been implicated in inflammation, and I
I
think
think the tricky bit is that then it can sound like, okay, so all I need to do is manage stress. But yeah, I'm not so sure that's hugely possible for humans to sort of eliminate stress or necessarily helpful. So then it can make people, I mean, maybe not all of us, but make it feel like, oh, it's my fault, or I've caused this flare because whatever, I was made redundant.
yeah,
You've got a whole extra layer of stuff
yeah,
going on that adds to the stress that's not necessarily under your control and certainly not your fault.
yeah. So you wouldn't necessarily look at that as a sole issue, and you wouldn't want people to feel bad about it, because that just makes things worse.
Yeah, but I guess there are some things, as we were sort of having a little look in the talk, that you might be able to do something about at different times, or at least being able to notice, I guess, the feeling that you have, or just yeah. I guess for me, it's helpful to think, yes, this is normal, that it's stressful being in a consultation with a doctor. That's normal. I don't know, darling, I'm good for it.
Well done.
Yeah.
All right. Well, I'll ask one more question, and then we'll love you and leave you for the weekend. But St. Mark's is a specialist centre, a very much specialist centre for obviously guts and bowels and stuff. And I imagine that the psychology service is going to be another really specialised service that's provided for that holistic care. Other regional hospitals, other places around the country, Scotland, Wales, we're not going to get the same type of in-depth psychology support that might occur at St. Mark's, are we?
Well, I think we are hopeful that we can be part of leading that change. When I say we, I mean Professor Hart in particular is very keen on this and sort of making the case nationally and internationally for more specialist psychology and IBD in particular. So yes, I think what we saw, because I think I was the first full-time diabetes psychologist in the UK for adults. And I think what we saw after Tower Hamlets and decided to do that initiative was that all the other London teaching hospitals had a look at things and went, no, we need to do that too. And then things changed quite quickly. So hopefully we'll be able to do a bit of disseminating and doing some research so we can also demonstrate this does make a difference. I think people who are living with conditions, kind of own voice and advocacy, and that is really important.
Yeah.
So there were times when I was working with people with type 1 diabetes in particular. I need to speak at the moment. Can you go away? Thank you.
Oh, we won't keep you too long.
Where where the service was saying, oh, we can't justify you doing this support group with people, which I was doing monthly. It wasn't, like I was doing it daily or anything. And the group themselves just said, no, we're not having that. This is important for the following reasons, and articulated all of it and went to hospital management with that. And they still have the group even without me. But people facilitating it because people made it quite clear this is important. This is why we need more of it, not less.
Is it, last question, I promise. Is it particularly difficult to recruit psychologists working with people with bad guts? Or no guts?
So I can't work out whether it's the gut thing that's off-putting to people, or what's this gastro stuff about? There aren't any psychologists doing that. That sounds very special. I'm not sure.
Yeah.
Or if it's the location that St. Mark's is in now, because we know it's been difficult to staff other bits of St. Mark's since it moved to Middlesex. But we do know we're about 20,000 clinical psychologists short in the UK, so that's part of it, that we just have massive competition from all other specialties and jobs and parts of the country for people to yeah, to pick the perfect job for them. And this may just be a bit out there. I don't know at the moment. We seem to
Wow.
be getting there. So the sorts of things that I try and do, I have trainees with me, as I was mentioning, but go and teach on courses. So part of what I was doing today was going back to the course who taught me at UCL. So trying to kind of keep those connections going and talk about what I'm doing with different colleagues, so it's not so out there. Yeah.
Well, if there's anything that any of us lot can do to try and make the whole concept of psychology and guts more interesting, then we'd be delighted to help out if we
That'd be
can.
great. Yeah, I think as
You're
people come
these
into
people
post,
in.
we're going to need all of that input to try and make services that are right to
Yeah, well, part of the benefit
between
is
what you need.
that multidisciplinary, fabulous support with really fabulous experts who are really specialists in the areas, and you're one of them. So, listen, I know you've got company, and so we'll take no more of your time. But I'd really like to thank you on behalf of everyone who's listened in and everyone who downloads for your great insight tonight. Really good, interesting stuff. I'm going to be breathing in a different way for a little while. But thank you very much indeed, Sonia. It's really
Lovely
nice.
to meet everyone.
And thank you for your time. And if there's no more questions, we'll let you get off and enjoy your weekend. And thanks again very much. Just a quick reminder to everyone, 1st of July, we have the monthly Zoom pouchy catch-up relaxing thing. So we'll be posting some reminders, but you're all welcome. It's usually more than an hour of fun and informal chat about pouchy related stuff. Sometimes not pouchy related, but it's very informal and you don't have to say anything if you don't want to. And there's the AGM going from the nice and comfy to the AGM. It's an obligation on us as a charity to have an AGM every year. That's happening on the 25th of June. I would say if you've got other things to do other than attend the AGM, and I can't believe you wouldn't want to listen to me which on about the charity and how we've done for the year. If you've got other things better to do, then please vote online. Gary might even post the link for you to proxy vote, which means you make the vote, but then it's your vote is represented at the meeting by me. But it means that we get quorum for the meeting, which is really important. That's it. Great. Well, listen, thank you all.
Thanks, Sonia.
Carry on enjoying your summer. Thank you again, Sonia. All the best. Have a great weekend, everyone.
Thank you.
Bye.
Bye. Bye.
Bye.